before lunch.
I've been trying.
Yeah, page 41. The mother of all lectures. Maternal newborn overview. Oh, by the way, try to come back after lunch, because after lunch I actually do the most important review in the whole lecture, and the whole review is this afternoon. So don't, you know what I mean? It really, it's critical that you be there for that. Okay, maternal newborn overview. Pregnancy. You must be able to calculate a due date. If you can't calculate a due date, you're in trouble, because everybody else knows how to do it. So here's how you do it. Take the first day of the last menstrual period. The first day of the last menstrual period. Add 7 days, subtract 3 months. Now you can do it another way, but if you don't have a way, that's a good way. So I'm going to give you a date, and I want you to figure the due date, and then talk to your buddy. Her last menstrual period was June 10 through June 15. Her last menstrual period was June 10 through June 15. I want you to figure her due date, and then see what your buddy said. June 10 through June 15. Okay, what do you say? March 17, exactly. Because you got to start with June 10, because that's the first day of the last menstrual period. Add 7, that's 17. Subtract 3 from 6 is 3, that's March. All right, so that's how you do that. Letter B, the weight gain. You need to know how much weight a woman should or should not have gained. Do not worry about multiples. Don't worry about women that are underweight or overweight to begin with. They don't go there. They're just talking about an average, typical pregnancy, which no one has, but the book describes. Okay? The total weight gain for pregnancy is 28 pounds plus or minus 3. 28 pounds plus or minus 3. That's the total weight gain. And here again, we're not talking about multiples, and we're not talking about women who are under or overweight to begin with. Number 2, in the first trimester, she gains 1 pound each month. 1 pound each month. How long is the first trimester? 3 months, so she gains a total of 3 pounds in the whole first trimester. So there's not much weight gain in the first trimester. So if they give you a woman who's had a fairly significant weight gain in the first trimester, that's bad. Because you really should not be gaining much weight in that first trimester. Maybe 3 pounds. In the second and third trimester, she's gaining much faster. She's gaining 1 pound per week. So how do you calculate? Because here's what you have to be able to do. On your licensing exam, if they give you a woman in a particular week of gestation, you have to be able to predict what her weight gain should be. For example, what if they ask you this question? A woman's in her 28th week. She has gained 22 pounds. What is your impression? And then the A says she's just fine, B says she's underweight, C says she's overweight, and D says, well, she could be either way, so do an assessment. She gained 22, she's at 28 weeks. How many of you know the answer? Know it. How many don't know the answer? How many aren't sure? How many aren't voting? Okay, the answer is, I'm going to show you an easy way to get that answer. Easy way. Here's how you do it. How do you calculate a woman's ideal weight gain? Do you see the chart there? We're going to fill in the chart. At week 12, that's the end of the first trimester. How many pounds should she have gained? 3. So put 3. At 13 weeks, she gained another week, so she gained another pound for a total of 4. Total of 4 to that point. 14, another week, another pound for a total of 5. 15, another week, another pound for a total of 6. 16, another week, another pound for a total of 7. 17, another week, another pound for a total of 8. 18, another week, another pound for a total of 9. 19, another week, another pound for a total of 10. 20, another week, another pound for a total of 11. Do you notice how every time she gains a week, she gains a pound? Now, what is the constant mathematical relationship between the top row, the weeks, and the bottom row, the weight gain? A difference of 9. A difference of 9. Take every top number and subtract 9 from it. What do you get? The bottom number. 12 minus 9 is 3. 13 minus 9 is 4. 14 minus 9 is 5. 15 minus 5 is 6. 16 minus 5 is 7. 17 minus 5 is 8. 18 minus 5, 9. I'm saying 5. You know what I mean? So, if you want to know the ideal weight gain for a pregnant woman, what do? Take the week of gestation and subtract 9. And that's what she should have gained, plus or minus a couple pounds. So let's go back to our example. What week did I say the woman was at in the example? 28 weeks. I said she gained how many pounds? 22. Okay, well, what should she have gained? 28 minus 9. 28 minus 9 is 19 pounds. She gained 3 more than she was supposed to. That is in the area of something could be wrong, let's assess. If she's within a pound or 2, she's okay. If she's 3 pounds off, you need to assess her. If she's 4 pounds off, there's trouble. So if a woman is in her 31st week and she's gained 15 pounds, 31st week, 15 pounds, what answer will you pick? Well, 31 minus 9 is... You don't have your calculators, do you? 22. She was supposed to have gained 22. The question said she gained 15. What do you think? What's that called, a biophysical profile on the baby? Because the baby may have died last month. Do you see what I'm saying? And we don't know. So that's bad. So can you predict the ideal weight gain for every week of gestation? Yes. Sure. Just subtract 9 from it. Which is a good OB number to begin with, isn't it? So ideal weight gain equals week minus 9. That's your formula. Letter C, let's talk about the fundus, fundal height. What's the fundus? Not a river in India. What is it? The fundus is what?
Upper part of the uterus.
It's the top part of the uterus. Well, it's not palpable until week 12. So can you palpate the fundus anytime during the first trimester? No. So if they give you a woman for a first trimester checkup and they say, you can't palpate her fundus, should you panic? No, you're not supposed to feel a fundus. What if she's gained 10 pounds in the first trimester and that fundus is way up here? What do you think? She's either not first trimester or she's got that hydatidiform mole, that molar pregnancy, that cancer thing that's bad. Okay, that's in the blue book. All right. Second and third trimesters, they want to know, when's it at the belly button? When is the fundus at the umbilicus, the belly button? And that is 20 to 22 weeks of gestation. 20 to 22 weeks of gestation. Now, why in the world would they want to know if you know those two things? What two things? Well, the fact that when do you palpate the fundus? At the end of the first trimester. When is it at the belly button? About 22 weeks. Why is that important for a nurse to know? Think about those 12 weeks and 22 weeks. What are those weeks?
Miscarriage and fetal demise.
Close, because you're dealing with what idea? Date of viability, which is 22 to 24 weeks, which is in the end of the second trimester. So isn't 12 at the end of the first trimester? And isn't 24 the end of the second? So can you use fundal height to determine in what trimester a woman is in? Yes. That's why they want to know it. Because if some woman comes in an auto accident or an accident of some situation, she's brought into the ER, she cannot tell you what trimester she is in. Because either she's had no prenatal care, she didn't know she was pregnant, or she's unconscious and able to tell you she's pregnant. You have no history. She's positively pregnant. You need to know what trimester she's in to know what that going on with that baby, right? Well, how can you real quickly put her in the correct trimester? Palpate her fundus. Because if she's pregnant and you cannot feel the fundus at all, what trimester is she in? And who's the priority, the baby or her? Her. If you can palpate the fundus, but it's at or below the belly button, you know she's in the what? Second. And who's the priority? Her or the baby? Her. But if that fundus is above the umbilicus, you know she's in the third. Who's the priority? The baby or the mom? The baby. Are you seeing how they'll work that and who will get the attention and what they'll decide? So those are gross estimations of gestational age. Okay, signs of pregnancy. Do you remember learning probable, presumptive, and positive signs of pregnancy? How many remember those three categories? Good news, there aren't three categories on boards, there's only two. Positive and everything else. So they lump the probables and presumptives together. You are not going to be asked to tell the difference between a probable and a presumptive. You will be asked to tell the difference between a positive and one of the other two. So you've got to know your four positive signs. They are fetal skeleton on x-ray. If you x-ray the abdomen and there's a skeleton there, you're pregnant. You can protest all you want, but you're pregnant. Number two, a fetal presence on ultrasound. If they do an ultrasound and there's a baby there, you're pregnant. C, auscultation of a fetal heart rate. Auscultation of a fetal heart. If they put a Doppler down there and there's a rate of 140, it's a baby. Your bladder doesn't have its own pacemaker. You've got a baby down there. Now, when does that occur? Somewhere between 8 and 12 weeks. You can hear it somewhere between 8 and 12. Now, it starts beating at 5, but you can't hear it until 8. Which brings up a really important point about OB questions. Most OB information, because it's OB, has a range where it occurs, because every woman is different, right? And they give you a range for everything. There's a range for quickening, there's a range for lightening, there's a range for viability, there's a range for fetal heart, there's a range for fundal heights. There's always a range for everything. Because of that, be real careful in OB questions. This is critically important to remember. Really carefully read your OB questions, because there could be 3 different questions for every fact in OB. The first question would be, when would you first? Got that? When would you first? That's one form of the question. The second question would be, when would you most likely? And the third question would be, when should you buy? When would you first? When is it most likely? And when should you buy? Those are 3 totally different questions for the same fact. In other words, when would you first auscultate a fetal heart? The answer is 8 weeks. When would you most likely auscultate a fetal heart? 10 weeks. When should you auscultate a fetal heart by? 12 weeks. Do you see that? So whenever they say first, pick the earliest part of the range. When they say most likely, pick the midpoint of the range. And when they say should buy, pick the end of the range. And a lot of times you're missing OB questions, not because you don't know the correct range, but you're not paying attention to which one of those they want. So when is quickening? When the baby kicks. Remember, quick, kick, quickening, kicking. When does it happen? 16 to 20. So when would you first feel quickening? 16. When would it be most likely? 18. When should you? By 20. Do you see the difference? 3 totally different questions for every single fact. If you don't know that, you're going to miss questions thinking even though you know the information. Okay, letter D, the fourth positive sign of pregnancy is when the examiner palpates fetal movement or outline. So what does not count as a positive sign? When mom does. It's when the examiner does. Okay, let's turn the page and talk about the other signs, the maybe signs. We lump the probables and presumptives together and we call them maybes. Letter A, all urine and blood tests. All urine and blood pregnancy tests are maybes. They are not positive signs of pregnancy. I'm going to make a statement. You don't have to write it down, but this is the reason why everybody gets confused about this. Here's the true statement. A positive pregnancy test is not a positive sign of pregnancy. That's true. And that's why everybody gets confused about positive signs of pregnancy, because they think a positive pregnancy test is a positive sign. No, it is not. It's only probable or presumptive. So a positive pregnancy test is not a positive sign of pregnancy. Does everybody know that?
Why not?
Because it only means you have the hormones that go with pregnancy. And many, many times you may have the hormone increases that go with pregnancy, but you don't have a fetus. And so a lot of positive pregnancy tests are false positives. But when you hear a heartbeat down there, there's no false positives on that one. Okay? It's a good question. I could phrase it the other way in what relation to what you asked. Is positive signs of pregnancies have no false positives. Are things that never have a false positive. Okay, let's talk about some other probable presumptive sign. Have you heard of Chadwick's, Goodell's, and Hegar's signs? Hopefully you've heard of this. 2 things you need to know. In what order do they occur? It's easy. They occur in alphabetical order. So who comes first? Chadwick followed by Goodell followed by Hegar. See, boards is more interested in if you know the order than if you know the exact weeks. Why? Weeks vary from woman to woman, but the order never varies. So boards is going to test what does not vary because it just is statistically more valid to test that. Or reliable, I should say. Well, what is Chadwick's sign? Chadwick's sign is a cervical color change to cyanosis. A cervical color change to cyanosis. What do you notice about all those words? They start with the letter C, and what does Chadwick's begin with? C. So Chadwick's is everything that starts with C. A cervical color change to cyanosis. It turns blue. And if the cervix is doing it, the vagina is too. Okay, Goodell's sign is cervical softening. And Hegar's is uterine softening. Doesn't that order make sense? What would happen first? The cervix would turn blue, then the cervix would soften, then that softness would move up into the uterus. So it kind of makes sense, the order does. Okay, let's talk about some patient teaching in pregnancy. You need to teach the woman the pattern of office visits. Good prenatal care is a major factor in reducing infant mortality. So you need to know how to teach a woman how often she should come in for good prenatal care. So you teach her to come in once a month until week 28. So through the whole first trimester and the whole second trimester and even into the third trimester, she's coming in once a month. Then at week 28, she should come in once every 2 weeks until week 36. Then she should come in every week until delivery or week 42. What happens at week 42? Do you schedule her for another office visit? C-section or an induction? So let me ask you this. If a woman comes in for her 12th week checkup, when does she come in next?
1 month.
16. If she comes in for 16, when does she come in? 20. If she comes in at 20, when does she come in? 24. If she comes in at 24, she comes back at 28. At 28, she comes back at 30. At 30, she comes back at 32, 34, 36, 37, 38, 39, 40, 41, 42, take the baby. So that's basically the way it goes. All right, another thing you have to teach her is that her hemoglobin will fall, and that's normal. We don't worry about low hemoglobins with pregnant women until it gets really low. The normal female hemoglobin level is 12 to 16. In the first trimester, it can fall to 11 and be perfectly normal. 11 is not low, tolerable. 11 is normal for a first trimester pregnant woman. It's not low, but tolerable. It's actually normal. It's not low. It's normal. In the second trimester, it can drop to 10.5 and be normal. Not low, but normal. In the third trimester, it can drop all the way to 10 and be normal. So what would you call a 10.1 hemoglobin in a woman's 37th week? Acceptably low or normal? Normal. So acceptably low might be as low as 9, you see. So I guess my point is this. Tolerate lower hemoglobins in pregnant women the further along they are than you would with other non-pregnant people.
What was the number for the first trimester?
11. It can fall to 11 and be normal. Which brings up the discomforts of pregnancy that you need to teach her. How do you treat morning sickness? What trimester problem is it? First, and what do you treat it with?
Crackers.
Dry carbohydrates. Yeah. Dry carbohydrate for breakfast, yes or no? No. It's dry carbohydrates before you get out of bed. Because once you're out of bed, it's too late. Number 2, how do you deal with urinary incontinence? This is a first and third trimester problem. Why do they not have a problem with urinary incontinence in the second trimester? Why do you not get urinary incontinence in the second trimester? Because the baby is in an abdominal pregnancy. It's up high off the bladder. But in the first, it's right down on the bladder, and the third, it's right down on the bladder again. How do you treat it? Void every 2 hours. A pregnant woman should void at least every 2 hours all the way from the day she gets pregnant until 6 weeks after delivery. Every day, all through labor, delivery, postpartum, pregnancy, void at least every 2 hours. Number 3, difficulty breathing. This is a second and third trimester problem. And you teach them tripod position. Can anybody explain to me what tripod position is? Feet flat.
Arms on the table with your
Arms on the table, leaning forward. So that's tripod. Or you can even put your arms on your hands on your knees, leaning forward. It's what you see COPD clients doing. Okay, back pain. People with pregnancy get back pain. It's usually second and third trimester. It just keeps getting worse and worse and worse. How do you treat it? Pelvic tilt exercises. Pelvic tilt exercises. So what that means is the woman should tilt the pelvis forward. You don't want them going like that because that hurts. So you're going to see women do this. That's what they do. They put this and they tilt that pelvis forward. That's classic pelvic tilt. Another way to do it is have them put their foot on a stool and that tilts the pelvis forward. Boards usually says this one. Okay, that's pregnancy. And you say, that's all? Well, there's some in the blue book, but pregnancy is a great place to use your common sense because pregnancy is not a disease. It's a healthy state. And so using good health patterns and ideas. So when you get a pregnancy question you don't know the answer to, what should you say?
Dehydration.
Well, what would be good for anybody? What would be a really good, healthy response here for anyone? Pick it and you will be surprised at how well you do. Okay, let's get this baby out of here now. Okay, let's go into labor and birth now. Letter A, what is the truest, most valid sign that a woman is in labor? How do you know a woman's in labor? What's the most valid sign she's in labor? What's that?
Bloody show.
Not bloody show. Not water breaking, because you can have both those and never be in labor.
Contractions.
Okay, but the woman doesn't call you and say, I'm dilating and I'm effacing. So what will they call it? What will they report? They call that the onset of regular progressive contractions. The onset of regular progressive contractions. That's the most valid sign that a woman is in labor. Isn't it possible to have your membranes rupture and 2 days later you still aren't in labor and they have to C-section you? Yeah. So that's not a good indicator. But it's associated with it, but it's not the best. Okay, terms. Here again, you have to know a vocabulary. You have to know what the words mean in OB or you can't answer the questions. So I just want to be sure you guys know these words. Dilation is the opening of the cervix, the opening of it. And it goes from 0 to 10 centimeters. So what a cervix that is 0 is described as what? Closed. A cervix that is 10 is described as fully dilated. Or, because open's not the best, fully dilated is the best. In America, in the United States, do we use centimeters or inches, generally speaking, in our lives? We talk about inches. We don't use centimeters. Most Americans don't know what a centimeter is. They know what an inch is, but they don't know what a centimeter is. Then why do we use 10 centimeters and 0 centimeters in OB? Why don't we use inches? Because most of our obstetric history comes from England. And we use very much an English system. But I also think in America, just think about marketing and 10 centimeters is 4 inches. I don't know how many women would sign up where they have to push a baby out a 4-inch hole. Do you know what I'm saying? So 10 centimeters sounds a lot more what? Generous, doesn't it? Oh, you're 10 centimeters. Oh, I can do this. So I know that's interesting. Okay, effacement. Effacement is thinning. 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 Thinning of the cervix. It gets thinner. And it goes from thick to 100%. So a cervix that is not effaced is described as what? Thick. A cervix that is completely effaced is called 100%. So how does a woman begin labor? Thick and 0, or thick and closed, or thick and 0 centimeters. How does she end labor? Fully dilated and fully effaced. Which what numbers? 10 and 100%. Okay. All right. Station. Station is the relationship between the spine. The fetal. I'm sorry. I was getting in lie. Station is the relationship of the fetal presenting part to mom's ischial spines, and you must know the ischial spines. This word is very important to know in OB. Ischial. The ischial spines are the smallest diameter through which the baby has to fit to be born vaginally. It's the tight squeeze, so to speak. It's the narrowest part of the pelvis. And if the baby can't fit through there, it cannot be born vaginally. If it can fit through there, it can be born vaginally. Station will tell you that. Now, negative stations means that the presenting part is above this tight squeeze. Positive numbers means the baby's presenting part is below, has already made it through the tight squeeze. So if a kid stays at -1, -2, -1, -2, -1, -2, -1, -2 for 17 hours after they're fully dilated and effaced, what do you know? Head's too big, C-section that lady. But what if a kid stays at +4, +3, +4, +3, +4, +3, +4, +3 for 17 hours? What's that tell you? Can the baby be born vaginally? Yes, because it's already made it through. It needs a vacuum extractor. It needs an extra little, maybe an episiotomy or just a forceps. So how many of you have a hard time remembering positive numbers and negative numbers? Which one's high, which one's low? Nobody does? Okay, I used to screw that up all the time. So I guess you don't. Okay. I had a way to remember it, but since you don't have that problem, we'll go on. Engagement is station 0. So what's that mean? If it's station 0, what's that mean?
Equal to?
The presenting part is where? At the ischial spines. Station 0. Yes?
Will you give me your clue in case I get nervous?
I always remember that positive numbers are positive news, negative numbers are negative news. Now what do I mean by that? Well, if you go into a woman's room and she says, what station am I at? And I tell her a negative number like -1, -6, that's negative news to her, which means where's the baby? Way up, and it's not coming down. But if I walk into a woman's room and she says, what station am I at? And I give her a positive number like +4, +2, what kind of news is that? Positive news. Good news. What's good news to a woman in labor? Baby's coming out, it won't be long now. So negative numbers are negative news to a woman, positive numbers are positive news. Negative, negative, positive, positive. That's the way I remember it. Otherwise, I always got screwed up. Lie. Lie is the relationship between the spine of the mother and the spine of the baby. In other words, between the spine of the mom and the spine of the baby. If mom's spine is like this and baby's spine is like that, that's good. That's called a vertical lie. That's compatible with a vaginal birth, uncomplicated. Another lie is if mom's spine is like this and the baby's spine is perpendicular. That is bad. That is called a transverse lie. And you see how I use the perpendicular as the T. And that is also trouble. It's bad. So whenever they give you these questions about lie, they will tell you where mom's spine is in relationship to baby's. Alrighty? If they tell you that mom's spine and baby's spine are parallel, touchdown, we got a baby. Score. Good. Baby's coming out. If they tell you the mom's spine is this way and the baby's spine is that way, make that. And what's that make? A letter what? Which means it's trouble and transverse. So you either got a baby or you got trouble. Presentation. Presentation is the part of the baby that enters the birth canal first. This is where you get all those wonderful little alphabet soups. R-O-A, L-O-A, R-O-P, L-O-P, R-M-P, R-S-A, R-S-P. Punt all of that. You do not need to know all of that. Let me just show you a little poll. How many of you know all of that? How many of you don't know that? My point is proven. Okay, how many know that before you give digitalis you take an apical heart rate? How many know that? How many do not know that? What do you need to know? The presentations or the dig? Because everybody else knows the dig. You better know it. Nobody else knows this other stuff. So why would you spend 2 weeks memorizing it? You're going to forget it anyhow, right? If they want to ask a hard OB question, they pull this out. What's the damage to you to missing a hard question? There is none.
No,
There is no danger to you in missing a hard question. Where's the danger to you?
Missing the stuff everybody
Missing
else
an easy question. Everybody's going to get hard questions. Everybody will. You can miss every single one of those and still pass with flying colors. You cannot miss the easy ones. So the goal is not to memorize or know everything. The goal is to know what everybody else knows so that your knowledge doesn't look any different than everybody else's. Do you understand what I'm saying? It's sort of like a National Geographic special, Boards is. And you're all a pack of zebras. Who gets picked off by the lion? The one that's what? Lagging by itself, all staying with the herd is good. So in nursing, stay with the herd, okay? So hopefully now, the most common presentation is ROA or LOA. Right occiput anterior, left occiput anterior. Okay, now, so if they ever give you a question where they say, you palpate a bulge here and an irregular there and a lump here and a round there, and then they say, what presentation is it? Hey, I'm picking ROA or LOA because I've got much better chances picking those two than anything else, and you'll probably be right. So that's just a good guess. ROA, LOA. And I'd pick R before L. 4 stages of labor and delivery. There are 4 stages of labor and delivery, and you must know them. Stage 1 is labor. All of labor is stage 1. And labor has 3 phases. Do you remember that? There are 4 stages that are big, and then 3 phases that are small in the first stage. So the phases are latent, active, and transition. And those phases are all in the first stage, which is called labor. Question?
Yeah. Going back to what you said about, doing the easy questions, why do they tell us if we get a bunch of hard questions, that's good because we're above that?
Yeah, if you get a whole bunch of hard questions, you have passed. Because you can only get to the hard questions by having mastered the easy ones. And the only way you can fail is to, for some reason, mess up easy ones. Whether due to your anxiety, just not understanding what they were asking, or not having certain basic knowledge that you should have, or not knowing how to answer certain kinds of questions. But I was sitting at a table in Cleveland at a national conference of the National Councils of State Boards of Nursing that write the test. And there were 8 of us at the table, and Ann Wendt was sitting right there, 2 people away from me. And Ann Wendt is the president of the National Council of State Boards of Nursing. She's the top NCLEX writer kind of person in the nation. And we were asking her questions. And one question I asked her, I said, Ann, people are always asking me, what do they need to do to pass? In a nutshell, what do they need to pass? And she looked at me, she says, I'll answer that in one question, one short answer. She said, they have to get to the hard questions. So if you want to pass, you have to what? Get to the hard questions, where you're going to miss a whole lot. But you've got to get to the hard questions, because if you never get to the hard questions, you will never pass. You see what I'm saying? Because you're always bouncing around down on the easy ones. And I didn't think that was that helpful, but at least it tells me that is because it came from the source authority on that. So she says you got to get to those hard questions. So the upshot of that is, don't panic when they're asking you about stuff you don't think anyone's ever heard of, because you're probably getting hard stuff, and that's okay. It's okay to get hard stuff. You want to get hard stuff. All right, stage number 2. Oh, by the way, what are the 3 phases?
Latent.
Latent, active, transition, in that order. What's the first phase? Latent. What are the first 3 letters of the first phase? L-A-T. What are those? The initials of this phase is in order. L for latent, A for active, T for transition. So the first phase, the first 3 letters of the first phase tell you the order of the phases. Stage 2 is called delivery of the baby. Stage 3 is delivery of the placenta. And stage 4 is recovery. Stage 1 is what? Labor. Stage 2 is delivery of baby. Stage 3 is delivery of placenta, and recovery is the 4th stage. Now, I would ask you, how long does recovery last? Does anybody know? Just 2 hours. It lasts for just 2 hours. So let me ask you this. What is the purpose of uterine, and this is what Hesse loves to ask, what's the purpose of uterine contractions in the first stage? In the first stage, what's the purpose of uterine contractions? No, that's stage 2. Dilate and efface the cervix. What is the purpose of uterine contractions in the second stage? Push the baby out. What's the purpose of uterine contractions in the third stage? Push the placenta out. What is the purpose of uterine contractions in the 4th stage? Stop bleeding. Yeah, to contract the uterus, to stop bleeding. So can anybody tell me when postpartum technically begins? When does postpartum technically begin?
After recovery.
And give me some more data on that.
2 hours after recovery.
2 hours
2
after?
hours after recovery.
Not after recovery. 2 hours after delivery of the placenta. There you go. So 2 hours after that placenta comes out, they're in recovery, and then when that ends, they are now in postpartum. Postpartum does not begin when the baby comes out. Does everybody see that? Okay. So do you see where people get messed up? They get messed up between second phase and second stage. Because if I ask you, what is the number 1 priority in the second phase of labor? Number 1 priority in the second phase of labor, what would it be? Pain management, right? But if they change the word phase to stage, and they said, what's the number 1 priority in the second stage? Now what's the number 1 priority in the second stage? clearing the baby's airway. You see what I'm saying? So you have to be careful if you know what would be an extremely important nursing action to undertake in the third phase. What do nurses do? What kind of actions are nurses engaging in the third phase? We're checking dilation, we're helping her with pain, we're helping her with breathing, because she's in the last intense part of labor to dilate, right? But if I said, what's a major nursing action for the third stage, what would you say? Yeah, watching for blood loss. What's the third stage? Okay, so what do you do with that? Yeah, make sure it's all there. Make sure there's 3 vessels in the cord. But you would never do that in the third phase because you don't. Do you see what I'm saying? So you understand how if you aren't paying attention to whether they're talking about stages or phases, you're gonna get messed up. Can you do that? Please keep phases separate from stages, because you have a first phase and a first stage. You have a second phase and a second stage. And you have a third phase and a third stage, but you only have a fourth stage. All right. Now let's go through those, and we'll go to lunch here in a little bit. Let's try to do the next 2 pages, and then we'll be done, but maybe we won't. The rest of this moves fairly quickly, because there's really not a whole lot. I mean, it's just a lot of fill-in. D says the first stage of labor and delivery. What's it all about? The first stage. What's it called? Labor. So what you see here is what we call the labor chart. Bad news. You have to know it all. You have to know the whole labor chart. Good news, though, I'll show you a way to remember it that's really easy, so you don't have to memorize it all. So let's talk about this labor chart. How many phases do you see in the labor chart? 3, because how many phases are there to labor? 3, and there's latent, active, and transition. Let's talk about latent. In the latent phase, you dilate from 0 to 4 centimeters. Your contractions are 5 to 30 minutes apart. That's the first column. We're going down the first column. So the contraction frequency is 5 to 30 minutes apart. The contraction duration, meaning how long they last, is 15 to 30 seconds. And the intensity of the contractions is described as mild. Now that's our word, not hers. Now let's talk about active, because things pick up here. Dilation goes from 5 to 7 centimeters. The frequency is every 3 to 5 minutes. They last 30 to 60 seconds, and their intensity is moderate. Again, our word. However, in transition, things pick up even more. The cervical dilation goes from 8 to 10 centimeters. The frequency is every 2 to 3 minutes. And the duration is 60 to 90 seconds. And the intensity is strong. Now, the way they will test your knowledge of this is they will say, a woman comes into the labor and delivery suite. She is 5 centimeters. Her contractions are every 5 minutes apart, and they last for 45 seconds. What phase is she in? Active. That's how you do it. But you have to know the numbers to put her in the right one. Good news. This chart is what we call a 3-column sequential table. Meaning there's 3 columns, and where one leaves off, the other picks up. And where that leaves off, the next one picks up. The easiest way to master a 3-column sequential table is to ignore the sides and only memorize the middle column. So I only want you to memorize active labor. Just active, which is what? 5 to 7, 3 to 5, 30, 60. And you got the whole chart, don't you? Because anything less intense would be what?
Late.
And anything more intense would be transition. So 5-7, 3-5, 30, 60. It can't be simpler than that. Note. Do you see where it says note? Contractions should not be longer than 90 seconds or closer than every 2 minutes. You must know this. They love to test this one. How do you know a woman's in trouble in labor? Well, when her contractions are longer than 90 seconds and closer than every 2 minutes. You do not want to see that. They would give you 4 women in labor and say, who's in trouble? Her contractions are going to be longer than 90 and closer than 2 minutes. That's bad. They'll also ask it, what are the signs of uterine tetany? Well, contractions longer than 90 seconds, closer than every 2 minutes. What's uterine hyperstimulation? Contractions longer than 90 seconds, closer than every 2 minutes. What parameters would make you stop Pitocin? 90 seconds, 2 minutes. 90 seconds, 2 minutes. Remember that. You're very likely to see that. Okay, let's talk about assessment of contractions. You have to tell the woman how to do this, how to time her contractions. Well, frequency is beginning, that goes in the blank, beginning of one contraction to the beginning of the next. So if you're teaching a woman to time frequency and these are 2 contractions, what letter interval would you tell her to time for frequency? A beginning to C beginning. That actually includes the contraction, doesn't it? So frequency is beginning to beginning. Duration, on the other hand, is beginning to end of one contraction. Beginning to end of one contraction. So what number sequence would you tell her to time for duration? A to B or C to D. So frequency would be A to C. Duration would be A to B, C to D. Intensity is the strength of contraction, and it's purely subjective. However, that next sentence is really important. You see where it says palpate with? This is very important. Teach her to palpate with one hand, always one hand, because the other hand is timing. One hand over the fundus with the pads of the fingers. So make sure you teach her to use one hand. Make sure you teach her to go over the fundus, and make sure you tell her to use the pads of the fingers, which are the fingertips. Okay, let's talk about complications of labor and then go to lunch. Bad news. There are 18 complications that can occur in labor and delivery, and you have to know them all. Good news. There are only 3 protocols you need to know for all 18. So really, what do you have to memorize? 18 different things or 3 different things? 3. So let's talk about these 3 things you need to know. The first one is painful back labor. Have you heard of painful back labor? It's usually when she's OP, occiput posterior. You know, LOP, ROP, occiput posterior. I always tell people, when you see OP at the end of it, think O pain, because they're going to have it. OP is O pain. So what do you do for it? 2 things. Position, then push. You position her, and then you push. In what position would you place her? Does anybody know which position you put a painful back labor in?
Side.
Not side. Knee, chest. She goes on her hands and knees with her rear end up and her head down. Because that brings the baby down off the sacrum and coccyx. So knee, chest. Get her on her hands and knees. Then push. What do you push? Anybody know what you push? Take your fist and push into her sacrum, because that applies counter pressure and actually relieves some pain. Yes?
Wait, I'm confused. You said knee to chest, but do you,
Knee chest.
but then you said, how are you gonna, if they're laying back in bed, are they on all fours? Or?
No, knee. See, knee chest.
I mean,
Yeah, people get knee chest confused with lithotomy. Because in knee chest and lithotomy, your knees are to your chest in both. This is lithotomy. This is not what we're talking about. This is lithotomy. Okay? Okay? That's lithotomy. This is knee chest. That's knee chest. See? So your knees are to your chest here and your knees are to your chest here. But this is lithotomy. This is, and here's the nose, that way. And this is knee chest here. Because see, the baby then will come down off the coccyx. So knee chest is that. Okay? That's knee chest. Right? And that's what we mean. We don't mean this. Next one, prolapse cord. This is bad. This is a OB emergency. Prolapse cord is bad because the baby can kill itself. Prolapse cord is when the cord is the presenting part, which means comes out first, so that when the head comes down, what's the head do? Press on the cord and the baby dies. Baby literally commits suicide and kills itself. So this is not cool. Painful back labor. High priority, low priority. Low. Prolapse cord, high priority, low priority. High. Okay, what do you do here? Push, position. Now what was painful back? Position, push. This one is push, position. So they're just the flip-flop. Well, what do you push? You don't touch the cord. Push the head back up. Push the head off the cord. Then what do you position her in? Knee chest. The one we just talked about. So she's in knee chest. You've got your hand pushing the head. And you stay that way till they pull it out C-section. So it's kind of, you have to ride on the cart with her. You know, so you just throw a blanket over everything. You just go like this, you look like a float, you know, in a parade. It's kind of weird. So what do you do for painful back? Position push. What do you do for prolapse cord? Push position. Do you remember I said usually I will always position before I do something else? That has an exception too, because in prolapse you push, then you position. Why do you push first in prolapse and position second in prolapse? Why? Because delaying pushing in order to position would increase the risk to the baby. See, but it's the same principle. So when you're sitting there not knowing what to do, it's probably good to you to think about, if I delay doing this to do that, would it... That's probably a good way to think. All right, number 3, interventions for all other complications and labor and birth. And there's like 16 of them. Uterine tetany, uterine atony, uterine hypertension, uterine hypotension, maternal subclavian syndrome, vena cava syndrome, just you name it. There's beaucoup complications. They're all treated the same. And they are treated with Lion, L-I-O-N. L means first you turn them on their left side. There's the L, left side. I is increase IV. O is oxygenate them. N is notify physician. So first you turn them on the left side, you increase the IV, you give them oxygen, and you notify the physician. Now LPNs, you will be able to do all of those except increase the IV. So what do you do for maternal hypotension? Line. What do you do for eclampsia? Line. What do you do for toxemia? What do you do for uterine rupture? Line. What do you do for, you see what I'm saying? As long as it's not painful back or prolapsed cord, you're picking what? Line. Question? Question?
We were just talking about first and best for the situation. So the first again would be positioning and oxygen would be best.
Probably the first would be, the position, and the best would be tough. The left side there might be the best too, because that gets the pressure off, gets the placenta perfused better. So even if you give oxygen and the placenta is not being perfused, it's not going to get to baby. So I would say that's one place where first and best are the same one, left side. Would everybody agree with that sort of? Okay. And sometimes it's the same. It's just on occasion it's different. And most of the time it's different. On occasion it's the same. Okay. PIT. PIT means in a crisis, if Pitocin is running, stop it. In an OB crisis, if PIT is running, stop it. So could that be the first thing you would do? So that would catapult all the way to where? Hold the PIT would catapult to what order? Number 1, and that would be L. So you'd stop the PIT, then LION. But most of the time they will not tell you PIT is running, so PIT won't even be there. So 9 times out of 10 you'll be doing LION. But if they tell you PIT's there, stop PIT, LION. Okay. Pain medications in labor. Get this down word for word and then we'll go to lunch. Do not administer a pain medication to a woman in labor if the baby is likely to be born when the med peaks. Do not give a pain medication to a woman in labor if the baby is likely to be born when the med peaks. Let me illustrate how you're going to do this, because it's not going to be anything magical. It's just going to be good common sense. What about this question? You have a prima gravida. Prima gravida means what? First timer. Prima gravida at 5 centimeters who wants her IV push pain med. Will you give it to her or not? Well, the question is it likely that a prima gravida at 5 centimeters is going to deliver in the next what? Well, IV push meds. We learned the other day that IV push meds peak when? IV meds peak when? 15 to 30 minutes after you give them. So is it likely that a prima gravida at 5 centimeters will deliver the baby in the next 15 to 30 minutes? No. So would you give her the med? Yes. What about this question? You have a multigravida at 8 who wants her IM pain med. Well, the question then is it likely that a multigravida at 8 centimeters could deliver in the next, well, when do we know IM's peak? 3260. Is it likely that a multigravida at 8 could deliver in the next hour? Yes. So what would you say to her? No. Are you getting it? And it's going to be obvious. It's not going to be, they're not going to play around with being real close like your teachers in school and ATI and stuff like that does. You know what I mean? They're going to make it clear. If you can pass HESI, you can pass ATI, you can do boards. You can. They are much harder. I would rather take state boards any day of the week than take an ATI or a HESI. That would be a no-brainer. Okay, after lunch, we'll come back and do fetal heart tracing. Be back at about, try to be back at 5 to 1.
I'm gonna run all the way to fill my car up. Gas.
Part of this kinesthesia is done, or is that too specific?
That's too specific. Part of dyskinesia generally is funny eye movements, funny eye movements, and stiffness. There's odd eye movements, odd tongue movements, and stiffness. That's part of dyskinesia. The dystonia usually is muscles anywhere. Part of dyskinesia.
Yeah, I know why you want to do
this.
this. Okay.
That's more dystonia.
Okay. All right. Thanks.
All right, we're going to talk about fetal monitoring patterns. There are 7 of them that you should know. Don't panic because they're actually easy to remember. I'm going to go through here and tell you which ones are okay and which ones are bad and what to do for them. All right, so that's the way we're going to go. The first one is a low fetal heart rate. That means under 110. This is bad. When you see it, you do lion, L-I-O-N. Left side, IV, O2, notify. And if PIT were running, what would you have done? Stop the PIT. High fetal heart rate. That's a fetal heart rate over 160. This is no big deal. You would document it and take mom's temperature because it's probably mom has a fever. That's based, but there's nothing wrong with who? The baby. Baby's just fine. You don't have to do anything specific. If you did anything, you'd take mom's temperature. That's basically all you do. It's no big deal. It's not a high priority. Low baseline variability. This is bad. This is when the fetal heart rate stays the same and does not change. Whether high or low or in the middle, it just stays the same. It doesn't change. That's bad. That's bad. And what you do is lion, L-I-O-N, left side, IV, O2, notify. High baseline variability. What that means is baby's heart rate is always changing. That's good. Document it. Now it's kind of interesting. Once a person is born, if their vital signs stay the same over time, what do we call them? Stable, and they are in good shape or bad shape? Good. But before you're born, if your vital signs stay the same over time, it's low baseline variability and it's bad. You want to see, so what we want to see before you're born, we don't want to see after you're born, and what we want to see after you're born, we don't want to see before you're born. So we want to see vital signs all over the map when the baby's in utero. That's called high baseline variability. That's good. We don't like to see stable vital signs, which is low baseline variability. Late decelerations. Decelerate means to slow down, and late means near the end of a contraction. So the heart rate slows down near the end or after a contraction. This is bad. So what you do is lion, L-I-O-N, left side, IV, O2, notify. Early decelerations. What would this mean? Early decelerations. Baby's heart what?
Slows.
Slows. Why did you say slows? Decelerate. When? Before a contraction or at the beginning of a contraction. And this is fine. This is normal. It's no big deal. So you just document it. Which brings up the last tracing. Variable decelerations. This is very bad. Think of variable, very, 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 variable, very bad, variable, very bad. So when you see variable, think, oop, very bad. How very bad? Well, this is prolapse chord. This is what happens when you prolapse a chord. So what do you do for this? Push, position. So of the 7 abnormal fetal heart tracings, which one is the most unique? Variable. And it's very bad. So it's the only one which is treated by push position because it's prolapse. Now, if we look at the remaining 6, how many are good and how many are bad? 3 are good, 3 are bad. What do you notice about all the ones which are bad? They begin with the letter L, which is the first letter in lion. So if you get a fetal heart tracing that begins with the letter L, what do you do for it? Lion. And so is it good or bad? Bad. So if it doesn't start with an L, it's okay, unless it's variable, in which case it's very bad. So if you want to know your fetal heart tracings, just look at the first letter. Starts with L, it's bad, it needs lion. If it doesn't start with L, it's okay, but if it's variable, it's very bad. It needs the prolapse routine, the push position. So do you feel a little bit better about those? There's one other thing I wanted to show you that tells you what they are. You know, what are they? What do they mean? And I'll see. You probably have heard of it, but for some of you that haven't heard of it, this might work. I've told you what the implications of them are, but what are they? Write the word veal, you know, like young beef veal. So write veal vertically down, and then write chop, like lamb chops, pork chops, veal chop. Do you see what I'm saying? So veal chop. Now what this is this is the first letter of the tracing, and this is the first letter of what it means. So variable would be what? V would be variable. That is cord compression. Do you see that? Variable is cord compression. What would this stand for, the E? Early. Decel. And that's what it is. What it's caused by starts with an H. So what would that be? Head compression. What would A be? Well, we didn't talk about it, but it's high fetal heart rate. Acceleration, which is high fetal heart rate, correct? And that's okay. Okay, meaning it's fine. Remember we said that high fetal heart rate was okay? What would L stand for? Late decel. And what would that stand for? Starts with a P. Placental insufficiency. Placental insufficiency. So veal chop, variable cord, early head, accelerate, okay, late, placental. Veal chop. Yes?
So when we get into the test and we have all these mnemonics and stuff, when would you recommend the best time to be to write it down, write the stuff down?
When you need it.
Oh, okay.
Not at the beginning.
Okay.
They'll give you a little whiteboard kind of thing, and you'll use that for your scratch pad. When you fill it up, you raise your hand, they bring you another one.
Okay.
You don't erase. They don't like you erasing. They'll freak out if you're erasing. So I would erase just for that purpose. In fact, what I would do is I'd go like this. But I would be doing absolutely nothing. You know, I wouldn't really be erasing. I'd just be going like this just to freak them out. Okay? They can make me take this test. They can make me sit there, but they can't make me behave. So I always think a little civil disobedience goes a long way. You know, are you in control in this test? No, you have to go take this test. You have to sit where they tell you to sit. They have to take the questions you have to take. You have to do it. So do something, civilly disobedient. Wear a pair of clown ears. I don't know. Don't wear underwear. I don't know. Do something that's where you can sit there and you can say, I'm in control. To give you a little edge. Okay. Ace of Spades. An ace of spades means what answer always wins in a tie. There are certain answers which they're always winners. They just win all the time. And in OB, there is one answer that always wins. And if you've ever worked OB, you'll know what it is. And that is check what? Fetal heart rate. You cannot work OB if you don't know that. No matter what happens in OB, no matter what happens in OB, what is the one question that surfaces all the time? What's the fetal heart rate? She's doing this and doing that. Well, what's the fetal heart rate? Well, this is doing that. Well, what's the fetal heart rate? So you'll always check a fetal heart rate. All right, that's the first stage of labor and delivery, labor. Let's talk about the second stage of labor and delivery, delivery of the baby. This is all about order. What do you do in what order? Well, first you deliver the head. And you say, well, what if it's breech? Come on, don't go breech unless they say it's breech. Okay, go with the common. So it's a cephalic, so deliver the head. Number 2, suction the mouth, then the nose. It always goes alphabetical. You suction the mouth first, then you suction the nose. Then number 3, check for a nuchal, N-U-C-H-A-L, cord. What does nuchal mean? Around the neck. Nuchal means neck. So check for a nuchal cord. Then number 4, deliver the shoulders and the body. In that order. So first out comes the head, then you suction the mouth, then you suction the nose, then you check for a cord around the neck, and then you deliver the rest of the baby. Right? That's the ideal. Number 5, the baby must have an ID band on before it leaves the delivery area. A baby must have an ID band on before it leaves the delivery area. Okay, third stage of labor and delivery. What's this about? Placenta. 2 things you need to know here. Number 1, make sure it's all there. Number 2, check for a 3-vessel cord. Make sure the cord has 3 vessels, 3 blood vessels. How many of each? 2 arteries, 1 vein. Think of the woman's name, Ava. Ava. How do you spell Ava? A-V-A. How many A's are there? 2. That's 2 arteries. How many V's? 1. That's 1 vein. So the woman's name, Ava. 2 arteries, 1 vein. Okay, that's all you really need to know about the placenta. 4th stage of labor and delivery, called recovery, correct? Recovery. That's what goes in that blank, recovery. It's the first 2 hours after delivery of the placenta, right? Now, there are 4 things you do 4 times an hour in the 4th stage. So you're going to write 4 3 times there. There are 4 things you do 4 times an hour in the 4th stage. So what are the 4 things you do every 15 minutes, which means 4 times an hour in the 4th stage? Well, the first thing you do is vital signs. Vital signs. And you're assessing for signs and symptoms of shock, which is pressures go down, rates go up, you get pale, cold, and clammy. Pressures go down, rates go up, and you look pale, cold, and clammy. Those are the signs of shock. Anything that's called a pressure goes down, anything that's called a rate goes up, and that. Number 2, fundus. Check the fundus. If it's boggy, you massage it. If it's displaced, you catheterize. Number 3, the pads. The perineal pads. Check the perineal pads. Look to see how much she's bleeding. If she is bleeding excessively, she will saturate a pad in 15 minutes or less. So how often are you checking her? Every 15. And when you check her, you put on a new pad. You go back, it's 98% saturated. Is she in trouble or not? 98% saturated. Is she in trouble or not? How many say she's in trouble? How many say she's not? She's not in trouble. Because it has to be saturated, 100%, and 98 is not 100%. And when you learn these rules, you have to live and die by them. You can't start fudging. Do you know what I mean? You can't say, well, that's close to that. Then pretty soon you start, losing your anchors. So 100% means 100%. If it's not 100%, it's okay. But if you put a new pad on her, check her in 15 minutes, and it's fully saturated. If they say saturated, what does that mean? 100%, she's in trouble. But if they say 98% saturated, I'd say she's okay. Close, but she's okay. Number 4, roll her over. Roll her over. In other words, check for bleeding underneath of her. A lot of people will check the pads but won't roll her over, and that's not safe. Because could you saturate half a pad and bleed out underneath? So you gotta do both. So what do you do 4 times an hour in the 4th stage? Vitals, fundus, pads, and roll. Vitals, fundus, pads, and roll. You do those every 15 minutes in that stage, that phase, stage. Okay, turn the page and let's do postpartum. This is talking about postpartum assessment. What do you assess? And usually you're assessing this every 4 to 8 hours. It's either 4 hours or 8 hours. It just depends on whether she's stable or not. And what you're assessing is bubble head. Now there's a whole bunch of stuff here, but I only want you to highlight and know 3 of them. And I'll tell you which 3. The first B stands for breasts. This is not a real important one. The U stands for uterine fundus, and this is the first one you must highlight. This is an important one. Here again, you want it to be firm. If it's boggy, you massage. You want it to be midline. If it's not, you cath them. Just like in the recovery. But there's something new that they will ask here in postpartum, and that is the height of the fundus related to the belly button. Where do you find it? Because what they'll do is they'll tell you how many postpartum days it is, and you got to locate where the fundus should be. It's really simple. All you do is fundal height equals day postpartum. Fundal height equals day postpartum. Now what do I mean by that? Is this. If a woman, here's her abdomen, here's her navel, this is -1, -2, -3, -4, -5, -6. And it's the 4th postpartum day. And they want you to point and click. Okay, here's a hot spot here, hot spot here, hot spot here, one here, one here, one here, one here, one here, and one here. A, B, C, D, E, F, G, H, I. All right? And she's 4th postpartum day. which hotspot would you click on? G. Because that's how many below? 4. 4 below on the 4th day. Now be careful, because F will be there too. Why would you not click on F? It's displaced. You want it midline. So they will have hot spots so that you'll get the right level, but if you're not precise, you'll be off to the side, and you don't want to be off to the side. You want to be in the middle. Okay, the next two B's are bladder and bowel. They're not a big deal. Bladder and bowel. The L is lochia. L-O-C-H-I-A. This one is the second one you highlight. This is the second important one. They are rubra, serosa, and alba. Rubra, serosa, and alba. Rubra is R-U-B-R-A. Serosa is S-E-R-O-S-A. And alba is A-L-B-A. Now it occurs in that order. First, by the way, the lochia is the vaginal drainage. Rubra is first, then serosa is second, and alba comes last. Now they want to know what color they are. Okay, if you rub, do you see rubra has the word rub in it? If you rub and rub and rub something, what color will it turn? Red. So rubra is red. Serosa has the root rosa for rosy. If your cheeks are rosy, what color are they? Pink. So rosa is pink. And alba, if you are an albino, what color are you? White. So alba, albino, white. So rub red, rosy pink, albino white. Rubra, serosa, alba. Now the amount. 4 to 6 inches on a pad an hour is okay. Excessive is saturated pad in 15 minutes or less. It's the same idea. The E stands for episiotomy. Episiotomy. No big deal. It's an incision. The H stands for hemoglobin and hematocrit. No big deal there. They're not going to focus on that. The E stands for extremity check, checking the extremities. This is the third important one you must highlight. And right now, on this one, they're looking for thrombophlebitis. So they want to know what's the best way for you to determine if a person has thrombophlebitis or not. What's the best way? Exactly. Bilateral calf circumference measurement. Measuring their calves. How many have heard of Hohmann's sign? That's not going to be the best answer. Now, it's not a horrible answer, but it's not the best one. Because you can have a positive Hohmann's sign and have equal calves and not have thrombophlebitis. And you can have thrombophlebitis and not have a positive Hohmann's sign. So it's not as reliable or valid. Some places don't even want you to do it. A stands for affect. Means you're emotional. Don't worry about Bowlby's stages. You know, latching on, letting go, taking in, throwing up. I don't really know what they are. You know, but you've ever heard of those?
Yeah.
Don't worry about all that. That's nuts. And then D, discomforts. And there's really no big deal there either. So the three big things you're going to be tested on in postpartum are what? The fundus, the lochia, and about thrombophlebitis. Anybody ever work postpartum? That's the three big things you talk about in report. You know, where's the fundus? How's the lochia? And how are her legs? She got thrombophlebitis. Okay, turn the page. Let's talk about variations in the newborn. Yes? No, the number of days when things go all varies. Boris likes to test what does not vary. the lengths vary, but the order never varies, and what they are never varies. So it's just like with Chadwicks, Goodells, and Hegars. They're not going to say what week or what month. They're just going to say what order and what is it. Okay, variations in the newborn. All of these things are normal. So I just wanted you to know that. I'm not going to read it to you. You don't have to have it read to you. But all of these things are normal, even though some of them sound bad. Look at number 4. Erythema toxicum neonatorum. Sounds horrible, doesn't it? But it's just a rash. It's no big deal. The only thing specifically I would want you to know from this page, other than the fact that all these are normal, is the difference between number 6 and number 7. Because they always test about the differences between 6 and 7. Caput succedanum and cephalohematoma. What do they always want to know?
One bleeds and one doesn't.
What's that?
One's bleeding.
One's bleeding, and that would be hema. And then also what else? Which one crosses sutures, which one does not, which one's symmetrical, which one's not. The easiest way I know to memorize that is look at their initials. What are the initials of caput succedanum? CS. What could CS stand for? Crosses sutures. So the one whose initials are CS is the one that indeed crosses the sutures. So what about cephalohematoma? What are its initials? C or CH. Certainly not CS, so it does not cross sutures. And of course, the one that crosses the sutures is also the one that is symmetrical. So I always say CS stands for crosses sutures and caput symmetrical. And Leonid, on number 8, it's talked about the hyperbilirubinemia. Normal physiologic jaundice appears after 24 hours. So there's a reminder of the difference between physiologic jaundice and pathologic. Okay, the last page, OB meds. Top 10 group, you've got to know your OB meds. Now, good news, you don't have to know much about your OB meds, because you're not expected to be an expert in OB meds, but you've got to know generally what they are and just a couple of things about them. So rather than fill you full of all kinds of stuff you don't need to know, let's focus on what you do need to know with these 6 different meds. The first 2 meds are tocolytics, which stop labor. They are terbutaline and mag sulfate. These are drugs you give to women who are threatening prematurity and you want to stop their labor. Terbutaline, the only thing you need to know about it is that it causes maternal tachycardia. It speeds mom's heart rate up. That's really all they'll test on that one. That it stops labor and speeds up the heart. Mag sulfate will also stop labor. If you give a person a lot of magnesium, what electrolyte imbalance will you create? Hypermagnesemia. And you know that magnesiemias do the opposite. So a high magnesium makes everything go down, so the uterine contractions will go down. Well, the only problem is, so will everything else. So what will your heart rate do? Go down, write that down. What will your blood pressure do? Go down, write that down. What will your reflexes do? Go down, write that down. What will your respiratory rate do? Go down, write that down. And what will your LOC do? Go down, write that down. So, mag sulfate, yes, the good news is it stops the uterine contractions. The bad news is it brings everything else down too. Which of those 2 do you think are the top 2 that boards will check your knowledge on? Respiratory and reflexes. They'll want to know, what does mag sulfate do to the respirations and what does mag sulfate do to the breathing? And it lowers both of them. So, when you're giving mag sulfate to a patient, you must monitor what 2 things?
Reflexes.
Reflexes and respiration. What are your parameters for titrating the mag sulfate? And LPNs, what parameters would you use when you notify the RN about it? 12? Okay, so what do you mean 12?
12 respirations.
Yes, so as long as the respirations are above 12, what do we know about the mag? Is it okay or not? It's okay, but if it goes below 12, what do we need to do with the mag? Slow it down. LPNs, you notify the RN of that. What about the reflexes? What do we want for reflexes? 2. We want +2. So if it's +1, what do we do to the mag? Slow it down. If it's +3, what do we do to the mag? Speed it up. So what do we want? 12 and 2. We want at least 12 respirations and we want 2 reflexes. What we don't want to see is 11 and 1. We don't want to see 11 respirations and lower, and we don't want to see 1 reflex and lower, +1 and lower. So 12 and 2 is good, 11 and 1 is bad. Okay, the next class of OB drugs are the opposite of the tocolytics. They are the oxytoxics. Now the oxytoxics stimulate and strengthen labor. Remember, the tocolytics stopped it. These ones start it. The most famous is Pitocin. We've talked about it before. The big thing you need to know about Pitocin is it can cause uterine hyperstimulation, which would be defined as what? Uterine contractions what? Longer than 90 seconds, closer than every 2 minutes. If you see that, back off your pit. Remember that before from the last couple of pages? Longer than 90 seconds, closer than 2 minutes. The next drug that will cause your uterus to contract is methergine. And the only thing you need to know about methergine is it causes high blood pressure. Now, if it's going to contract blood vessels and contract the uterus, if it contracts blood vessels, what's it going to do to the blood pressure? Increase. Does it make sense that vasoconstriction increases blood pressure? So do you see the 2 M's, methergine and mag? They're both used in OB, methergine and mag, right? What does one do to the blood pressure? Lowers it. Well, the other one does what to the blood pressure? Raises it. So one of the M's lowers the BP, the other M increases the BPO. Okay, the next 2 meds are the fetal lung maturing meds. The meds to make a fetus's lungs mature faster. The first one is beta-methasone. What is it? Steroid. And the other is Survanta, which is surfactant. So just let me talk about 3 things you need to know about each. With beta-methasone, number 1, it is given to the mother. Mom gets the beta-methasone. Number 2, it is given IM. And number 3, it is given before the baby is born. Before the baby is born. And you can repeat it as long as the baby is in utero. However, Survanta, on the other hand, 3 things about it. Number 1, it is given to the neonate, to the baby, not to the mother. It's given to the baby. Number 2, it is given transtracheal, which means blown in through the trachea. And number 3, it is given after the baby is born, not before. Survanta is given to the baby transtracheally after the baby is born. Whereas beta-methasone is given to the mother, IM, before the baby is born. They both are given to make the baby's lungs mature faster.
I love it.
Cervanta is blown in.
What do they use?
They use a nebulizer kind of thing. They can even put it in a connection to a ventilator. Puff it in. Okay. That's it on OB. We're done with OB. That's the longest lecture of the whole review. That's why I like to split it up with lunch. Okay, we're going to go to page 51, medication helps and hints. This is a very short lecture just designed to help you get some basic facts down. Because if you don't know these facts and you miss these questions, you're in a major hurt. The first one is, what is Humulin 70-30? What is it? It's a mix of insulins, of R and N. Now you can have Lispro 70-30, but that's a variation. When they say 70-30, they're talking about N and R, basically. Now, 70 and 30 are percentages. So it means it's 70% one and 30% the other. Which one is which? 70% is N, and 30% is R. So if you give 100 units, which you would never do, it's way too much. But if you gave 100 units of 70-30, how many units of N would there be? And how many units of R would there be? If you gave 50 units of 70-30, how many units of N would there be? 35. How many of R would there be? 15. You see, it's just you just multiply the percentages. You know how to get a percentage? Just take that number and multiply by 0.7 for 70, 0.3 for 30. The way I remember that N is the 70 is 70-30 is like a fraction. What do you call the top term in a fraction? What letter does that begin with? N. So N is in the numerator. Number 2, can you mix insulins in the same syringe? Yes or no? Yes. When you draw it up, is there a certain way to do it? Which one comes first? Everybody says clear to cloudy. Boards doesn't use the words clear or cloudy. They talk about N and they talk about R. Now those of you that are taking the NCLEX RN, this will work better for you. But is that what you want to be? Then do it that way. RNs will do it this way, meaning draw up the what first? R followed by the N. That way you don't get into this clear cloudy garbage. Okay, RNs do it that way. Now if you're talking about pressurizing the vial, which vial would you inject the air into first? The N, then inject the air into the R, then draw up the R, then draw up the N. So it's N, R, R, N, but it always ends in RN. Injections. They will tell you what injection you're giving, and they will ask you what needle you're going to use. What needle will you use for giving a particular injection? Here's how you do that. If they say you're giving an IM injection, and they want to know which needle you'll use, 21 gauge, 5/8 inch, 22 gauge, 1 inch, 21 gauge, 1 inch, 25 gauge, 5/8 inch. And they want to know which one of those needles will you use for IM. The clue is in the abbreviation. Look at the first letter of the abbreviation. What number does that look like? A 1. Go pick the answer in which both parts have a 1 in it. Which one would that be? C would be your answer. Did you see that? Why is C the answer? Because both the gauge and the length both have a number 1, because an eye looks like a 1. Okay, but what about this? What if they changed it to sub Q? Here again, look at the first letter in the abbreviation. What is the first letter in the abbreviation? S. What number does an S look like?
5.
A 5. Go pick the answer that has a 5 in both of the parts. And the answer would be D. Because you've got 25 and 5/8. So when you're asked to pick a needle, just look at the abbreviation, look at the first letter, and go find the numbers. Okay, turn the page. We're going to talk about heparin and Coumadin because they're in the top 3 most commonly tested drugs on boards. If you don't know these, you're in trouble. Heparin versus Coumadin. Very, very important. Heparin. It is given IV or sub-Q. Coumadin is given only PO. See, I'm comparing and contrasting is what I'm doing, everybody. Go back to heparin. Heparin is working immediately. Works immediately. Go to Coumadin. Coumadin takes a few days to a week to work. Anywhere between a few days to a week. Go back to heparin. Heparin cannot be given for longer than 3 weeks. And in parenthesis put, except for Lovenox. Remember, the Lovenox can be given for a long time. Regular heparin cannot be. Yes?
4 weeks, you said?
3. Because in 21 days you start making heparin antibodies, which could be really life-threatening. Coumadin can be given for the rest of your life. Can you not? You can take Coumadin forever. Go back to heparin. The antidote to heparin overdose is protamine sulfate. They love that kind of stuff. Coumadin. What's the antidote to Coumadin?
Vitamin K.
Vitamin K. How do you remember that? Yeah, k and p. Heparin, protamine, Coumadin, K. Go back to heparin. The lab test that monitors heparin is the PTT. PTT, which is the partial thromboplastin time. They'll give you both names. The one that monitors the Coumadin is the PT, which is the INR, from which the INR is derived. Now the way I remember that is several ways. If you have your hands, you can go what? H-E-P-A-R-I-N. How many fingers are left? 3. P-T-T. Okay, let's spell Coumadin. C-O-U-M-A-D-I-N. How many fingers are left? 2. P-T. Or you can cross. You can write P-T-T, cross them together. What letter does that make?
H.
Which stands for? Heparin. Any of you guys computer people? Have you ever seen this? HTTP? Read it backwards. PTT is H, which is heparin. Okay? So you can do it either way, any way you want to do on that one. Heparin can be given to pregnant women. Coumadin cannot be given to pregnant women. Heparin can be given to pregnant women. Coumadin cannot be given to pregnant women. By the way, speaking of pregnant women, what's the only major antipsychotic tranquilizer that can be given to pregnant women? Remember all those zines and zapines? The only one that can be given is Haldol. Haldol is the only one you can give, antipsychotic you can give to pregnant women. Has nothing to do with what we're talking about, but I just thought we'd throw it in. The next thing is the K-wasting and K-sparing diuretics. K-wasting and K-sparing diuretics. Probably the only question you'll ever get about a diuretic is, does it waste K or does it spare K? The easiest way I know to do this is this. Any drug ending in X, any diuretic ending in the letter X, X's out K. So if it ends in X, it X's out K. So what is it? A waster or a sparer? If it ends in X, it X's out K. It wastes it, yes. Plus diuryl. So the K-wasters are all the diuretics that end in the letter X plus diuryl. If it does not end in an X and it's not diuryl, it's a sparer. So I'm going to give you a bunch of drugs and you tell me whether they're wasters or sparers. Spironolactone, aldactazide, Moderatic, sparing. Lasix, Bumex, Clotrix, Esidrex, Demodex, diuryl, wasting, and yeah, so you got it? Okay. And baclofen. Baclofen is the last drug I want to talk about. Boards test muscle relaxants as a class. And you need to know your muscle relaxants. Now, the only thing they test about muscle relaxants is the 2 side effects and the 3 teachings. 2 side effects and 3 things to teach. The 2 side effects of a muscle relaxant are fatigue and muscle weakness. Does that make sense? That a muscle relaxant would make you tired and relax your muscles. Fatigue and muscle weakness. The 3 things you teach are don't drink, don't drive, and don't operate heavy machinery. So what do you have to know about baclofen? What are the side effects? Fatigue. Or drowsiness, right? Drowsiness, fatigue, same thing, right? And muscle weakness. What do you teach them? Don't drink, don't drive, don't operate heavy machinery. Now the other drug that they test is Flexeril. F-L-E-X-E-R-I-L. That's the other muscle relaxant they test. Flexeril and baclofen are the 2 muscle relaxants they test. I am not going to teach you how to remember that Flexeril is a muscle relaxant, because if you can't figure that one out, I can't help you. Right? So Flexeril, you should remember, is a what? Because you flex your muscles. Well, how in the world are you going to remember that baclofen is a muscle relaxant? Well, I always say this. When you are on your baclofen, you are on your baclofen. Which means you're doing what? If you're loafing, what are you doing? Aren't you relaxing? So there's your clue. It's a muscle relaxant. Because baclofen puts you on your baclofen. It's a muscle relaxant. Yes.
Back to the wasting diuretic.
Yeah.
Remember how you said it might change things to more generic? What about
Yeah.
like furosemide and things
The
like that?
semides, SEMIDE are the X's. Semides are typically X's. Semides, SEMIDES. Not all of them, but most of them. Okay, let's talk about pediatric teaching on the next page. We've only got 3 left, guys. Actually, 3.5 left, so we're cool. This takes about 5-10 minutes, this one, because it's very short. It's just a review of Piaget's theory of cognitive development. Have you heard of that? You do need to know Piaget's theory, but they will never mention Piaget's name. They will test your knowledge of Piaget's theory of cognitive development by asking you how you would teach children. And you're supposed to, if you get a pediatric teaching question, that's a chance for you to show your knowledge of Piaget. So let's talk about it. Piaget has 4 stages for kids thinking. The first one is the 0 to 2-year-olds who are in the stage of sensory motor thinking. In the middle column, Piaget says these kids are totally present oriented. They don't think about the past. They don't understand the future. They only think about what they are sensing or doing right now. So, when do you teach these kids? Can you teach them ahead of time? Why? Why no? They don't understand the future. Can you teach them after you do it? No, they can't understand the past. So when do you teach them? While you do it. So when? While you do it. You teach them as you do it. What do you teach them? What you are doing. Do you notice the present tense there? What you are doing. And how? Verbally. Just tell them. Don't use play. They don't understand play. So if you get a kid from 0 to 2 years of age and he's going to have a spinal lumbar puncture and they want to know how you're going to teach him, what are you going to say? While we do it, we're going to tell him what we are doing. Bingo. That's all you do. There really is no such thing as pre-op or pre-test teaching for this age group. For this age group, who do you pre-teach? The parents, not the kid. Okay, the second stage of Piaget is the 3 to 6-year-olds. He calls them the pre-operational, which I like because 3 to 6 is a preschooler, correct? And he calls it pre-operational. So the 2 pre's go together. Preschooler, pre-operational. They are fantasy-oriented. They are imaginative. They are illogical. Their thinking obeys no rules. You cannot reason with a preschooler. If they can think it, it can happen. I mean, you can't, they're just, whatever. Well, do they understand the future? Yes. Do they understand the past? Yes. So when would you teach these kids? Would you teach them before? Yes. How long before? Or doesn't it matter how long? Shortly before. So here's the deal. Pick an answer that says the morning of or the day of. Or something like 2 hours before. That is fantastic preschool. Because you don't want to give these kids a whole lot of time to what? Get their imagination going on it. You see what I'm saying? My kids never, at this age, my kids never knew they were gone to the doctor's office until they pulled into the parking lot of the doctor's office. Otherwise, we'd have had disaster. That's why they never rode with me after that. No, what do you teach them? What you are going to do. What you are going to do. What tense are we talking in now? Future. What tense did we talk in with the younger ones? Present. So how old does a kid have to be before you can start using future tense verbs? 3, at least 3. Good. How? Play. These are the kids that learn through play. So in a nutshell, if you've got a 4-year-old who's going for a lumbar puncture, how do you teach him? When? The day of, you tell him what you're going to do using play. Some kind of a play thing. Alrighty? A story, a book, equipment, whatever. Dolls. Okay, the next stage are the 7 to 11-year-old concrete operations kids. The way I remember that 7-Eleven age is concrete is, have you ever seen a 7-Eleven grocery store? What's it surrounded by? Any flowers, grass, trees? No, just a bunch of concrete 7-Elevens. So just think of concrete 7-Elevens. You got 7-Eleven age concrete operations. These kids are rule oriented. They live and die by the rules. They cannot abstract. With these kids, they are so rigid. If you tell them this is the way it's going to be, that's the way it has to be. How many, at 7 to 11, that age group, how many ways are there to do things? One, and only one, and every other way is wrong. This is the age where the parent hears, the teacher said, and the teacher hears, my parents said. Now, have you ever taken care of these kids, this age group? Did you ever change a dressing for them or something like that? What do they always tell you when you change their dressing? You're doing it wrong. Which means what? You're not doing it like the other person did it. Now, are you doing it wrong? No, but they don't know that. They're so rigid. So, when do you teach them? Days ahead. Because they're not going to blow it out of proportion. If you tell them this is what's going to happen, 3 days later, that's what they think is going to happen. So you can teach them a day or two ahead of time. So how old does a child need to be before you could teach them the day before? 7. Now you can give a little one, a 3 or 4-year-old, a tour of the facility. You just don't tell them what's going to happen there. Do you understand what I'm saying? Tours are okay. You can give anybody a tour. What are you going to teach them? What you're going to do plus skills. What you're going to do, plus you can teach a 7 to 11-year-old how to do skills. You cannot teach a 3 to 6-year-old how to do skills. Why? If you teach a 7 to 11-year-old how to do a skill, how will they do it every time? Exactly the way you taught them, because they're rigid, concrete. If you teach a 3 to 6-year-old how to do a skill, how will they do it? Any way they can imagine. You know, you teach a 3, 4, 5-year-old how to give themselves insulin, they'll do it just fine for you. Then the next day, what will they do? Well, I think I'll not put anything in there and I'll just jab and out. And then the next day they go, oh, why don't I give it to the dog? That'll work. You know, and they just don't, ugh. So what age does a child have to be before you could teach them a skill? 7. How? Use age-appropriate reading and demonstration. Use age-appropriate reading and demonstration. Okay, the next age group are the 12 to 15-year-olds, and they are formal operations. These kids can abstract. That's the big, huge thing that they can do that the younger ones can't. They can abstract and they can think cause and effect. So here's the good news. As soon as a kid hits 12 and they ask you about teaching, it's not a pediatric question anymore. It's an adult med-surg question. Because when do you teach a 12-year-old and above? Like an adult. What do you teach them? Like an adult. How do you teach them? Like an adult. So, at what age is a child first taught like an adult? 12. Trick question. When's the first age that a child would be able to manage their own care? 12. Why can a 7-year-old do the skills related to their care? Could they manage it? No. What does manage mean? Make what? Decisions which require abstraction. Because if you got a board question like this, which of the following 4 children could manage their own care? A 7-year-old with cystic fibrosis? No. An 8-year-old with diabetes mellitus? No. A 10-year-old with a scraped knee? No. A 13-year-old with chronic renal failure? Yes. Why did they put the 10-year-old with a scraped knee in there? To fool you, because it's not the severity of the illness that determines who can manage, but the age of the kid. Why could a 10-year-old not manage a scraped knee? What will you teach a 10-year-old to do about a scraped knee? You'll tell them to do what? Wash it, dry it, put on Neosporin and a Band-Aid. Okay, what will he do the next day? Wash, dry, Neosporin, Band-Aid, because they do it exactly the way you said. So what do they do the third day? Wash, dry, Neosporin, Band-Aid. The fourth day, it's swollen. What will they do? Wash, dry, Neosporin, Band-Aid. The next day, there's pus coming out of it. What will they do? Wash, dry, Neosporin, Band-Aids. The next day, it's swollen twice the size of the other leg. What will they do? Wash, dry, Neosporin, Band-Aid. The next day, they're semi-comatose, and they've got red streaks coming up and down the leg. They can barely get out of bed. What will they do? Wash, dry. Are they managing? No. That's why they can't do it. But a 13-year-old with a chronic renal failure, if they are taught auscultate your shunt every day to hear a bruit, if they don't hear a bruit, what will they do? Get help. That's managing. Managing doesn't mean doing everything. Managing means knowing when you can and when you can't and what's necessary. So just be careful. If they say manage, it's a 13-year-old. If they say skills, it's a 7-year-old. All right. Let's go to page 58. I want you to read this. This is for you to read about and learn about. It's about how to take psych tests. All it is a bunch of 7 principles you have to obey. The first principle says, make sure you know what phase of the relationship you're in. Remember the nurse-patient relationship? Pre-interaction, introduction or orientation, working, and termination phase. Remember that? This tells you how to answer in each of those phases. The second principle is gift giving, which means don't give gifts in psych. Don't accept gifts in psych. If your schizophrenic gives you flowers, don't accept them. Why? Because to you it's just flowers. To them it may be a marriage proposal. And when you accept it, you're in trouble, okay? Number 3, don't give advice. If the patient says, what do you think I should do? What should you say? What do you think you should do? I know it sounds corny, but that's what they want you to say. Don't give them advice. Now, can you give advice in med-surg and peds? Sure, but not in psych. Because if a mother says to you, how should I care for my child's PICC line when she goes into the shower? You should not say, how do you think you should care for the PICC line when she goes? Do you know what I'm saying? It's stupid in med-surg. It makes sense in psych. Number 4, don't give guarantees in psych. Don't say, if you cry, you'll feel better. If you talk to me, we can help you. Remember, all those are guarantees. Don't do that. On that next page, immediacy, and you can read all about this. I'm just showing you what it's about. Immediacy says, if a patient says something, what's the best answer? The one that keeps them talking. If you're between 2 psych answers and you don't know which one to pick the one that keeps the patient talking. The one that says, let's talk about it right here and right now. Let's keep talking. Don't pick answers that say, refer them to the social worker. Why? If you're referring to the social worker, what are you doing to the communication right then and right there? Shutting it off. Don't do that. Even if it's appropriate for the social worker to deal with. Do you see what I'm saying? Keep them talking. It's never wrong to get your patient to talk. Did you hear what I said? It's never wrong to get your patient to talk. So if one of the answers gets that patient to talk, you better pick that. Because if you don't, you're saying it's wrong to get a patient to talk. It's never wrong to get a patient to talk. That rule alone can really help you on psych questions. If you're sitting there and you're between two answers, for example, like a woman has had a breast biopsy, and she says to you, when will the results come back? Do you think I have cancer? My sister had cancer. She died of breast cancer. What's your best response? And you're between A, which says, your results will come back in 2 to 3 days and the doctor will discuss them with you. Or B, which says, you're concerned about what the results may show. Both of those are okay. But one of them doesn't get her to talk. The other one gets her to talk. Which one gets her to talk? B. Now, is there anything wrong with A? It's absolutely 100% correct. But it says, the results will come back in 2 to 3 days. The doctor will talk to you. Talk to the hand that cares. You know what I mean? Talk to someone who cares, because I don't care. Whereas you're concerned about what the results may show gets her to talk. But you see, that's a real dilemma that a lot of people get into. So when you're between two psych answers, remember, it's never wrong to get the patient to, so it's probably always right. Okay, concreteness number 6 means don't use slang. You know, if the patient says, I feel rotten about what I did, don't say you feel rotten. Because then they go, oh, maybe I have, maybe I'm, rotting away. And don't tell an upset patient to chill out. You'll probably find him in the refrigerator. Because psych patients take you what? Literal and concrete. So don't say to a client, oh, what goes around comes around. Now they're going like this all day long, because they're worried about something going around and coming around. That's figurative speech. That stinks in psych. If a patient says to you, you're a real Brinslabik, what should you say?
What's a Brinslabik?
Ah, I tricked you. Brinslabik is not what? Concrete. So you wouldn't say, what's a Brinslabik? You'd say, you're confused about what my role is here. I know it sounds really stupid, but that's what they're going to say. Or you're a real Brinslabik. I see you're angry. You see what I'm saying? That's perfect. You don't use the dumb word they used. You know what I mean? You're a Shabazniak. What's a Shabazniak? No, you don't go there. Don't go. You don't, believe me, you don't want to go there. Now, you may want to go there because sometimes it's really fun to hear about it. It can be very entertaining, but that's what makes me a bad psych nurse. Okay. The one I want to camp out on is empathy here. You got to know empathy, because they won't license a nurse who's not empathetic. Believe me, they won't. Empathy says the best psych answers are those answers that communicate to the patient that the nurse accepts the patient's feelings as being valid, real, and worthy of action. Empathy is all about feeling. Do you remember we talked about this the other day? Acknowledge feeling. You're empathetic. Always be empathetic. Here are some really bad answers. If you ever see an answer written this way, don't even finish reading it. It isn't worth your time. Here's a really horrible one. Don't worry. Don't feel. You shouldn't feel. I would feel. Anybody would feel. Nobody would feel. Most people feel. All of those are as stupid gets. I saw a question in a review book that shall remain nameless called Saunders that said that a woman had a miscarriage and was crying. And they wanted to know what the nurse should say. And they said that you should say, I know how you feel. I had a miscarriage too. Now, it's true, you did have a miscarriage. You know what I'm saying? It's not that you're lying. But they said you should say that. I'm telling you, you never say that. That is the stupidest answer I've ever heard. You say something like what?
Tell me how you feel.
Well, remember, I don't like tell me how you feel. That's very upsetting. Yeah, that is so sad. Everything that has happened is so devastating. You see, we don't like to say, how are you feeling? We want you to look at the scenario and assume. Remember, you're always told, don't read into questions. But on these ones, you have to read the feeling into what's going on. This is the one place where you have to read into the question. If you don't read in, you're going to miss it. Because see, if she's crying and you say, how do you feel? That's kind of, well, how do you think I feel? You know what I mean? But I see you're so sad. This is just devastating. You know, that's good. You don't say, I know how you feel. I did it too. You know, who cares? Who cares? Okay, turn the page. I want to teach you a 4-step process for answering empathy questions. And if you use this, you will do really well with them. Number 1, recognize that it's an empathy question. Empathy questions always have a quote in the question, and each of the answers is a quote. Have you seen that format? Patient says, quote, da 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 da. What would you say? A quote, B quote, C quote, D quote. When you see that format, what should you say to yourself every single time? Chance for me to show my empathy. Okay, now here's how you do it. Because you're going to have to read. Aren't you going to have to read the feeling into it? Number 2, put yourself in the client's place, their shoes, and say their words as though you really, 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 really meant them. Be an actor. Get into it. Role play it. Number 3, then ask yourself, if I said those words and really meant them, how would I be feeling right now? Okay, now you got your answer. Now you got your answer. All you have to do now is, number 4, go and choose the answer that reflects that feeling or anything close. Do not choose the answer that reflects their words. Because these empathy questions always have what I call the sucker answer there. It's an answer that's wrong, but it's there to sucker you into answering it. And what it will reflect is what the patient said. But it will ignore what the patient felt. You're supposed to pick the answer that reflects what they felt and ignore what they said. Did you hear that? Empathy ignores what is said and goes with what is felt. Don't get it switched around. When people have a hard time answering empathy questions, it's usually because they respond directly to what the patient said rather than how the patient feels. Do you remember when, I don't know your name, but I said, you're a real Brinslevik? If you respond to what they said, you'll say, a Brinslevik? But if you respond to how they feel, you'll say, I see you're angry. Do you see the difference? Now, I want you to do the next 3 questions, practice questions, and I want you to use these rules. Put yourself in the client's place. Say the words as though you really meant them. Ask yourself, how would I be feeling if I said these words? Pick the answer that reflects that feeling. I also want you to identify at least one sucker answer that overemphasizes what the patient said but missed how the patient was feeling. So do that and then talk to your buddy. Stay on task. I'll be right back. The third one is really hard. That third one, the problem with it is when you put yourself in the patient's shoes and say those words, no feeling really pops out. So what you have to do is go to the answers and see what feeling the answers are reflecting and see which one has the most likely feeling. So go to your answers and see if you can get it that way. Well, let me ask you about the first one. She said, "You're killers, you all killed my mother, whatever, she died before I was born." How does she feel? If you said those words and believed them, how would you feel? Scared? Okay, now, go to the answers and find the answer that reflects being scared. Which one is it? B. What is the sucker answer? C. Because that focused on what she said. She isn't concerned about her mother. She's scared. She's frightened. So the answer is B. The sucker answer is C. The next one, what's the right answer? D. And a sucker answer is any of the others. Because the others focused on what he said. D focused on how he feels. Did anybody get an answer on the third one? What did you say? The answer is C. What's the sucker answer? B. Because B says religious. He's not feeling religious. He's using a bunch of religious what? Words. That's the hint that it's the wrong answer. He's feeling out of control. So that's why C is the answer. Because with those words, I can prove to you that he has a control issue. I can't prove to you that he feels religious. So C is the right answer. How many got C on that one? Wow, that's great. How many got all three? Terrific. If you missed any, do you see why you missed it? What were some of the problems you had with that? Anybody? Or you've learned from it? Any questions you have for me about those? Did you use the process? Did the process help? Okay, so that's what I want you to start doing. I don't want you guessing on psych answers. I want you to know the answer. You understand what I'm saying? So many times you guys just guess on psych answers. I want you to know why you're picking what you're picking. Okay. Take a quick break. Come back at 25 after, and we'll just do the last lecture and a wrap-up and be done. Okay? And the sooner you're back, the sooner we'll get done.